A very warm welcome to every one of us, especially those of us who are joining us for the first time this year. This is going to be our first Tesla. And on behalf of the entire Farmalab team, I want to welcome every one of us to the new year. This is going to be our first tele-education series for the year 2024. And we hope to have it all through the year in partnership with our various faculties of veterinary medicine. Today, I'm really very pleased to be introducing a topic that we are all very, maybe not very conversant with, but an interesting topic, cancer in veterinary medicine, dog as a case study. If we hear cancer in human beings, we are almost always very, very worried. But now in dogs, how worried should we be? So as a way of introducing, we have partners. And what's unique about our 2024 Tech Class session is that we realize that the various universities we have are a bundle of knowledge, right? I'm just in the private sector. Sometimes devise means to resolve. But our universities are designed to generate knowledge and also to ensure that we have those knowledge in the field working for us. So Farmalab thought it very, very necessary.
Dr. Femi, can you mute everyone?
Yeah, so I'm just doing that backend. I've done that backend. All right, so we for our maiden edition, we are partnering with the University of Ibadan, Faculty of Veterinary Medicine, University of Ibadan. We're soon going to hear the dean speak. And the idea is that various faculties of veterinary medicine will provide us the hub experts. Farmalab will provide the technical support. We provide the publicity, we provide the platform, and ensure that the entire veterinary community is well abreast of the innovation from those faculties of veterinary medicine. We have over 400 participants registered today. We are closing up to 100. I believe before we approach the next 15 minutes, we should have participants well over 200 or more. So we're partnering with the Faculty of Veterinary Medicine, University of Ibadan, and of course, our regular partner, Farmalab, MDoc, Boringa England, Making More Health, and Ashoka. I will be anchoring, moderating today's event. Dr. Esther will be coming up to say a brief about Farmalab, and then we will have a goodwill message from the Dean of Faculty of Veterinary Medicine, who is our technical host today. Then we will have a few quick quiz. You will answer a few questions just to gauge your knowledge. And we have three hub experts today, Professor Ayarefe, who is heading the Department of Veterinary Surgery and Radiology, University of Ibadan. We also have Dr. Richard Anita, who is a consultant pathologist and an adjunct lecturer in the same university. We also have Dr. Ekundayo, who is the Executive Director, Dove Heaven Foundation. I will be introducing them in full. Then we will have the entire lecture will take about 45 minutes. Then we will have an open participatory session, question and answer for 40 minutes. Then at the end of the 40 minutes, we'll have the hub experts select someone who summarizes the entire point for us so that we'll have our take-home lesson. Then we will have our post-quiz to gauge our knowledge. Then, of course, the announcement and next steps. So this is going to be the rundown of the activities for today. Just a few background. We're using video conferencing technology, Zoom, to leverage scarce healthcare resources. We are specialized, ECHO is specialized in best practice with colleagues. ECHO prides itself as a model that moves knowledge instead of moving people. I said earlier on, over 400 people registered for today's event across the country, not just in Nigeria, but across Africa and the world. And what we're doing today will be moving knowledge rather than moving people. So it's a lot more convenient. Our approach is case-based learning. We want to ensure that the knowledge from the university meets with the practical application in the field to ensure that we have a smooth ride. Then we also continuously monitor the outcome of the program. What we'll be doing this year differently is that the outcome of this program, we'll be putting it as a blog post, and then we'll be sharing among the various veterinary communities that we're part of. So please make note that we leverage on the ECHO model. We collect registration. Before you could join this meeting, you will realize that you are registering. So we collect registration, participation, question and answer. We monitor the knowledge gain. Our chats and comments are also being monitored. Our poll responses, individual data are kept pretty very confidential, handled by authorized personnel. This data may be used for reports, map, communication survey, quality assurance, evaluation, research, to mention but a few initiatives. And the University of Ibadan should be expecting a full detailed report of this meeting, including the participant, the graphs, the knowledge gain, and the impact you have made by hosting this technical session in your email a week from this meeting. So that's to just bring into the entire body an organized session. The session is recorded, and we'll be sharing a PDF version of all the slides with you after the meeting. So please point to note, if you can turn on your camera if you're well-dressed and your cameras are good. I will be able to unmute you if you need to speak. If you want to say anything and you need our attention, you can use the chat button or just simply raise your hands. There are a few people at the back end monitoring. And for any questions and observation, you can use the chat button. So before we proceed, I want to call back and can you spot Dr. Esther Lauren-Femi and let her give us a brief about Pharmalat. Also good to note that Dr. Esther works with us, and she's also a proud graduate of the University of Ibadan. So Dr. Esther, over to you.
Thank you very much, sir, for the introduction. Good morning, everyone. I hope you can all hear me. Yes.
Yes, we can hear you.
Welcome, everyone, to today's tech class session, and it's my delight to tell us about what we do at Pharmalat, who we are, what we do. So a quick history. Pharmalat is an animal health and social enterprise. It was established in 2019 with the primary mission of enabling easy access to affordable animal health care in Africa, especially in underserved communities. So we know, many of us know this, and we all actually know this, that animal diseases account for about 70% of losses in pet ownership and in livestock farming. And this is huge. And sadly, the animal healthcare system in Africa at the moment is not at its optimum. It leaves little to be desired of, and this goes a long way to adversely affect both pet owners and livestock farmers. And we all know that livestock farmers are the lifeline of our local food chain. So it is quite important that we pay attention to them, and this is what we do at Pharmalat. We've been able to combine our relevance as a major animal healthcare brand in the country with our mission to ensure that animal healthcare products and services are made available, they're easily accessible, and they're affordable. We've been able to do this for some time. Like I said, we started in 2019. So we have been able to partner, or usually every day we partner with local animal health professionals, mostly veterinarians, who are in direct contact with these pet owners and livestock farmers to build an inclusive system of sustainable animal health and disease prevention. So this is what we do at Pharmalat, and we've been able to successfully do this over a period of time. We also foster a peer-to-peer network where farmers and pet owners can have easy access to knowledge that they need, to veterinary services and even animal health products itself. So this we have done for some time. Our tech class session, like we are on, like what I said earlier, is we do in partnership with the largest private held animal health organization in Africa and the world, Moringa England. And Ashoka. Ashoka is an organization that supports social entrepreneurs. They do this through the Making More Health platform. Our education partners are MDoc. Dr. Femi has spoke much about them earlier. So it's my delight to welcome all of us to today's class session. And we do hope that we would have an amazing time. We believe strongly that we'll learn a lot, and we do hope that we'll put to practice all that we will be learning. Thank you so much, sir, for this opportunity. Thank you, sir.
All right, thank you, Dr. Appreciate it. And thank you for the work you do for us. And I'm happy you're also proudly University of Ibadan hosting this event today. So we will please enable the Dean, Faculty of Veterinary Medicine before we start our post-quiz. The Dean, Faculty of Veterinary Medicine, University of Ibadan. And I want to especially thank you, Ma, for making this a reality. Can we please search for the Dean, Faculty of Veterinary Medicine to give a goodwill message and declare the knowledge session open? Have we been able to spotlight her? Back.
Yes.
Fantastic. Can we spotlight her? She's Olufunke Backend. Fantastic. You're on, ma'am.
Good morning, ladies and gentlemen, dear colleagues and everyone. I want to welcome you to this first class session. Let me just say Happy New Year one more time, this 2024. And we are all welcome to a year that is filled with great, good, and abundant blessings. Continuing our theme of Vet O'Clock, we are hitting the ground running in this new year. And we are prioritizing our roles as jack of all trades and master of all. And to this end, we have decided to use our skills more appropriately and ensure that we are adequately prepared for the challenges ahead. Our main thrust this year remains capacity building, and the 14 veterinary schools are partnering with Farm Alert in a collaborative effort to increase our town to gown and shake to enable us take our rightful place in the building and rebuilding of our dear nation, Nigeria. And as the premier university, University of Ibadan, the first and the best, it is only right to commence the series of lectures here. And a very topical issue is this that we have chosen: cancer in veterinary medicine. The increase in some of these cancers in our animals and even humans is a challenge that we all need to rise to. And the experts are ready. We are all also poised to learn from them. It is my fervent hope that as we begin, we all will upscale our skills and be able to better care for our patients and improve our interaction with our clients. On this note, I want to thank Farm Alert again, and the CEO in particular, who is always in love with us, Dr. Femi Kayode. Thank you so very much for partnering with our veterinary schools. This is the first of its kind that we are having. And I can assure you, in this critical time that we are in our nation, we are not going to take this opportunity for granted. Thank you so much. And on this note also, I want to wish all of us a beautiful learning experience and more impactful work life in this new year, 2024. Thank you all.
All right, thank you. That's the Dean, Faculty of Veterinary Medicine, University of Ibadan. I think what I really didn't also emphasize is that she's the chairman for the Continuing Education Committee for the Veterinary Council. So she wears so many useful hats for us today. Thank you for always being warm and accepting all our initiatives. By the way, she's also the chairman, Committee of Deans. So you see.
And directors.
And
Committee of
directors, deans
veterinary
and
faculties.
and directors of all veterinary schools in the country. So happy to have you around. We are super proud that you're joining us and hosting the maiden edition of our partnership with our Faculty of Veterinary Medicine. All right, so right now she has opened the room for us. We are going to be starting with the pre-quiz. Now you could drop your names and your VCN number, but it doesn't really matter. We're using a special kind of Zoom that tracks your name as long as you're registered and you use the join link. It also tracks the number, the minutes you spent. It also tells us when you left, when you came in. So it tracks almost everything you do on the platform, and we have access to all those data. So you could drop your name, but if you're not dropping your name, that doesn't mean you're not specially captured. You are, and you're being also monitored in terms of the timing you spend here. So backend, can we start with the pre-quiz? The pre-quiz are just simple. So backend, let's put up the pre-quiz question, and we will have, all right, good. So they are just true and false questions, just to test what you know about cancer before we start. We have an entire 45 minutes of lectures, but we want to ask you if you understand what you're about to learn so that we can use that to gauge answers. We have about almost 170 people in the room already, and we have just 3 minutes to kick off and be done with this. So please, true or false questions. We have 12% participation, 13% participation. As soon as we get up to 60, we'll be closing the question and answer. True or false? That's all you just need to answer to. Then we will now be welcoming our hub experts in for an amazing 45-minute session. Thank you, thank you. So if you are done, you can just in the chat box, just click done so that we know. But 74 persons have answered the question and we are 170. So we are 45%, 47% participation now. So if you're done, just click done so we know that you have answered the questions. We will not be naming people and the answers they give. This is just to help us gauge the knowledge gain per session. So we have 56% participation. Thank you so much. Thank you so much. Thank you for clicking done. See a lot of people. 102 persons have answered, 103. We have 60% participation. So let's give another 1 more minute or 2 more minutes, 120 seconds before the countdown. 110 persons have answered. Look like we are all gurus in this cancer thing. That's why, you know, I was suggesting a bit of tougher questions, but you know, even as it is, some people, we still have varieties of answers. So it means that you might probably not know as much. Luckily, we have hub experts that will be putting us through. We have 65% participation now. 120 people have answered. We have almost 180 people in the room, 430 registered. So we're expecting to have 200 people join us. From our statistics, if we have 400 people registered, then we're expecting 200 at a single time live participate. We have 67% participation, 29, 28, 27, 26, 25, 21, 19, 15, 10, 5, 4, 3, 2, 1, and 0. So we have 71% participation, 180 people in the room, 130 persons have answered the question. So that's good enough. Thank you, everyone. Backend, can you please pull down end the quiz? And no, we are not going to share result now. We're going to share result at the end of the post quiz. So I'm going to be sharing my screen again so that I can introduce the hub experts. So we have 3 hub experts. Professor Ayerife is one of our hub experts today. DVM, MVSC, PhD, FCVSN is a seasoned veterinary surgeon, professor and head of Department Veterinary Surgery and Radiology, University of Ibadan, Nigeria. He's a chief consultant in soft tissue and orthopedic surgery at the Veterinary Teaching Hospital, University of Ibadan, where he also served as a member of the Hospital Management Board. He's a member of the steering committee, Small Animal Veterinary Association Nigeria. He's currently the editor-in-chief of the Nigerian Veterinary Journal. He's a recipient of many local and international grant awards that includes the University of Ibadan Senate Research Grant Award, John D. and Catherine T. MacArthur University Staff Development Grant Award. And he has, to his credit, over 70 publications, both in local and international journal. Amazing, isn't that? We also have Dr. Richard Eden Antia. He's a graduate of University of Ibadan, 1976. I wasn't born then. Thank you, Prof. Doc. With distinction in parasitology and pharmacology, many other qualifications he has. He has taught and supervised research projects at the undergraduate and postgraduate level in both diagnostic and clinical pathology, and was a consultant pathologist to the Veterinary Teaching Hospital. His research interest has been on clinical pathology, trypanosomiasis, and tumors in domestic animals. He has over 50 publications, currently an adjunct lecturer in the University of Ibadan. I also heard he has been a mentor to also one of our hub experts, which I will be reeling out now. So Dr. Ekundayo Samuel is our last but not the least hub expert for today. He's executive director of Dove Haven Foundation, a cancer-focused non-governmental organization, president, Commonwealth Scholars and Fellows Alumni Association, Nigeria. He's a registrar in the University Teaching Hospital, University of Ibadan, lecturer in the Department of Veterinary Physiology and Biochemistry, Oncology Unit, Faculty of Veterinary Medicine, University of Ibadan. He's a former Digital Health and Cancer Research Fellow at Oncopadi Technology Limited. Dr. Kundayo is a University of Ibadan scholar and has received several awards, including Commonwealth Spirit Site PhD Scholarship, University of Perth, UK, RCSBDD Dent Young Award, UK, Aspect Monitoring Network Award, first from Nigeria and Africa, super proud of that, United States of America, prestigious CAS Future Leaders Award, USA, first from Nigeria also, congratulations, African Civil Engagement Academic Award, University of Georgia. So that's our 3 hub experts and people who will also be presenting our case study. I want us back in at this moment, we have over 200 people already in the room. To please spotlight Dr. Samuel Ekundayo, who will be giving us our first presentation for today. Spotlight, fantastic. Dr. Ekundayo, will you want to share your screen?
Okay. Can you see my screen?
Fantastic. Ladies and gentlemen, please welcome Dr. Ekunda Yo Samuel to take the next 10 minutes. Go ahead, Dr.
Okay, thank you so much for the opportunity to present at this meeting. I want to also thank the director, Veterinary Teaching Hospital, and my mentor, the Dean of the Faculty of Veterinary Medicine. I hope you can see my slide, Dr. Ofemi.
Yes, we can. Go ahead.
So this is a topical issue, and I think is worth looking at. And as I've been introduced, I represent the Veterinary Teaching Hospital as a registrar, and also speaking from the human perspective, also as the executive director of the Living Foundation. So I think it is time we begin to look into the issue of cancer, and I'm happy that a lot of awareness is actually ongoing. And we have done some work from the angle of the human perspective, raising awareness about cancer, and I'm trying to do a lot of screening activities all over the country, especially in the rural communities. And I think cancer is very expensive, so there's a need for us to begin to look at the issue of funding. And that is why it is good that we bring it into the veterinary part. Now that we're talking more about the issue of One Health, I think it's good that we look at cancer from every angle, because as at the moment, we don't really know what causes cancer, except one major cause that we know in human, and basically maybe one or two in animal. So I think it's good that we explore more to see how to take care of cancer. So you'll be asking ourselves, I know we are all medical doctors, veterinary doctors here present. So, but we can ask what is cancer? And I think it's a thing that we need to look at. What causes cancer? What is the link between gene and cancer? How is cancer diagnosed? Can cancer be prevented? So these are what can be coming to our mind. And I think it's good that we also know that, yes, I think it's starting from here. And I'm very hopeful that after this meeting, we'll begin to see a lot of people coming into the space of cancer, knowing fully that is a major problem at the moment, both human and animal. So who can have cancer? You can know that puppies can actually be predisposed to cancer. Even old dogs can actually be predisposed to cancer. Female dogs also, they can have cancer, and also male dogs. So invariably, every animal can have cancer. So that's actually what we are actually looking at here. So, and what are the common myths in cancer, especially in animal? We'll be asking ourselves, cancer is a non-communicable disease. In human, yes, but in animal, that is not true. Cancer is a non-communicable disease. In human, yes, but in animal, that is not true, because we have some transmissible form of cancer in animal. So that would not be true if you say cancer is a non-communicable disease. So all cancers are hereditary? No. We know that all cancers, within 5 to 10% of all cancers, they have genetic factor linked to them. However, not all cancers are actually linked to gene. So we also know that applying herbs will treat the disease, yes or no. So these are all myths that we are still not very, very sure about, that we have to be careful about. So some people will say that if you ignore the symptoms, they will go away. That is not true. Some will say that an abnormal screening result means your dog has cancer. That is not true. Some also say that pain is an early sign of cancer. That is not true. So dog don't need to get screened. That's also not true. You need to get your dog screened, even though there's no symptom. You have to get your dog. So some people also say that cancer is an affliction from evil spirits. Some people say it's also an affliction from your neighbors. That is not, if you have issues with your neighbor, you can say, oh, because of my neighbor, that my dog has cancer. No, that is not also true. These are what we see as myth flying around, and some also say that cancer in dog is a dense, and that also not true. So cancer actually is actually an abnormal growth due to uncontrollable proliferation of cells. And this actually starts from the basic science that we know from cell, that every cell will divide from 1 to 2, 2 to 4, 4 to 8, 8 to 6. So that is the normal way. But the moment your cells begin to divide uncontrollably, that's why there is what we call a cell cycle clock that helps to regulate how your cell divide. So when there's any abnormality with the DNA that, or all the genes that are responsible with cell growth or cell division, that clock will send a signal to all the checkpoints in the cell cycle clock to say, okay, stop this cell from dividing, then the cell will not divide. Then that cell can easily be arrested or will actually be destroyed if it cannot be repaired by all the checkpoint genes like the P53, P21. So they will say move here. So most of the time, cancer cells evade this process. They hijack this process of cell proliferation, therefore causing these genes and proteins to mutate. And when they do that, the cell begins to divide uncontrollably. So all those genes that are involved in suppressing the tumor, they will all be downregulated, or they move to the mutant state. So from there, the cell begins to divide. And before you know, we have a lot of cell piling up, and before you know, they form a lump, they form a growth, initially from benign. And if that is not well taken, or if they are aggressive, they begin to spread. However, know that cancer is called cancer because they are malignant, and that means that they started spread. So any tumor that you see that is actually in a place, you can't really say it's cancer. Cancer is cancer when it begins to spread. That's actually what we call cancer. So you must understand that anything that you see is just staying there like a lump. That is not yet a cancer. So you can call that a benign tumor. But the moment that those cells begin to spread to the nearby tissue, basically to the lymph node, maybe from there to the blood, then from there to other, then we call that cancer. So cancer is not cancer until it begins to spread. So I think we need to get this right. If it's just there, that's actually what we call a benign tumor, not really cancer. So we call it malignant neoplasm, or you call it cancer. So those are the names that we need to get right as we move on. So cancer actually is not a single disease, just like malaria, just like TB, just like leptospirosis. Cancer is not a single disease because cancer is a disease of the body cells. So anywhere you see cancer cells in the body, that area of the body can actually have cancer. So you name the cancer based on the site or location where that cancer actually starts. So for example, if the cells in the breast are having issues and they proliferate and they become cancer, so you call it breast cancer. If it's dog, you call it mammary gland tumor or cancer. So you name the cancer basically from the location that actually is coming from. So cancer is not a single disease. So cancer is a multiple form of disease that actually affect the body. So that should be clear. And cancer now is a major public health issue. For example, in human, let's take for Nigeria, 2020, there was a statistics that came up in Nigeria, in the world, whereby initially lung cancer is actually the most common form of cancer. However, in 2020, breast cancer took over. However, most people die from lung cancer more than breast cancer, despite the fact that we have more of breast cancer. So in Nigeria, for every 10 cases of breast cancer patients you see in Nigeria, within a 5-year period, at least 8 will die. But when you leave this country, outside this country, for every 10 cases of cancer patients you see, at least 8 will survive. So that is why there is need for us in Africa to begin to look inward and begin to correct this, because it's actually not right. So, however, also, in sub-Saharan Africa, 80% of all new cases are found here, whereby we have less than 5% of the cancer resources globally. So this is actually what is happening in human. Now, you cannot tell how bad it will be if it comes to animal. And that's why I think it's good that we begin to speak about it and begin to work towards saying how to reduce this cancer burden. As at the moment, we know that cancer in animal is the leading cause of death, especially in pets. So cancer in animal, when the animal is aged beyond maybe 7, 8, 9 years, cancer becomes the leading cause of death. So when your animal is actually going older, you begin to look at how to look forward to seeing this monitoring symptom of cancer and the like. So cancer is prevalent in dogs compared to other animals because we have seen that dogs have been domesticated, and there are so many relationships now that we have between human and animal. That's why most of what you see in human cancer is actually what you also see in dog, unlike other animals where we have the reversal. So 4.1 million new cases are found in dog globally, although that figure is wrong because we know that in Africa, especially in Nigeria, we don't really have data to say that we actually contribute to this number. So this number actually, I'm not sure it captures what is happening in Nigeria because we don't really have data to say, yes, we have so number of cancer cases. So, but in the world, we have 4.1 million new cases of cancer and also 8.2 million reported across the globe in 2020. So 1 in 3 or 4 dogs are diagnosed with cancer in their lifetime. That makes it a public health problem. So cancer in dogs are often very similar to those in humans, as I've said earlier, because of the similar genetic risk. So according to the American Veterinary Medical Association, we're told that 50% of death in pets actually occur when they are more than 10 years old. Pets often tolerate chemotherapy better than people. That's what we have seen so far. And lymphoma, melanoma, and also sarcoma are the common shared cancer found in both pets and dogs. And I think it's good that we know the common type of cancer that we expect to see in some breed of dog. So basically, it's all about the DNA and the environment that actually we need to look into. So sometimes you find this in your dog, like a mole. That is not really a cancer. You can call it a benign tumor. So we find that most of the time in dog. So don't say, yeah, this is cancer. No, that is not really true. However, we have some form of cancer that we've seen so far in the clinical practice. We have the mast cell tumor, we have the imagiosarcoma, we have the lung cancer, we have the mammary gland tumor, we have the canine transmission venereal tumor. Both, what you're saying is actually the penile form of cancer, and also we have the TVT also in the female dog. Well, in the research in UI, we've actually increased our awareness about cancer of recent, whereby we don't just take chances. Anytime we see any swelling anywhere, any lump, we begin to investigate actually what actually is this. So we have people from pathology and people from so we can look at it together to see actually how we can move. So what are risk factors? Is anything that can increase a person's or animal chance of developing cancer or disease. So some risk factors actually, some are modifiable, some cannot be modified. In dog, actually, we have the DNA, that those are actually that can actually those are the hereditary form of cancer that we know. Like I said earlier, that 5 to 10% of all cancers, they have hereditary link. We also have the environment that can cause problem. Your dog that is smoking in dog will actually increase the risk of having cancer. Even so, alcohol intake in some dogs, we see that actually is also causing problem. These are not really found in Africa as it were, but this is actually what is happening in the world, where we have increased cases of cancer. We have also physical inactivities can also be a major problem. If your dog is not exercising properly, then you can be at risk of losing that dog to cancer. And also, the radiation that we have, at least we have the expert here that talk to us about surgery. So also, exposing your dog to radiation also can also increase the risk of having cancer. And also, dog having sexual multiple partners can also be a problem. And also, different breeds show different resilience to cancer. So some breed will not come down with cancer because of their genetic makeup. That's what we also find also in human also. Also, obesity also is a big problem. When your dog is overweight, then you stand a risk of actually having cancer. And you feed the dog with junk. So some of you feed the dog with different kind of food. I think you need to be careful to know that yes, this actually can predispose your dog to cancer. And also, what are the possible signs that you can see and say, this dog might, it's not that this dog is having cancer, but this dog might be actually having this, and let's go and do further screening to actually confirm what is this. So if you see a lump in your dog, you have to be concerned. If a dog is losing weight, it's actually emaciated, you have to be concerned. If your dog is lame, it's not walking well, is having a swelling, and you need to be concerned. Also, you can find out that sometimes you find bleeding from nose, from the orifices, you have to be concerned. If you find a wound that is not healing your dog, you have to be concerned. If a dog is having abdominal swelling, you must go and screen. Let's know what is the cause of this swelling abdomen. Also, if the dog is actually having labored breathing, you have to look at what will be this problem. And also, when your dog is stopped eating, loss of appetite, you must be concerned and go and do further to see what is. So basically, you can prevent cancer in 3 forms: primary prevention, secondary, tertiary. What we are doing today is actually the primary, because today we are giving education out. This is a form of primary prevention method of taking care of cancer. So if you screen your dog for cancer, those are secondary. And when the dog is coming down and you are going through surgery, you are going to chemotherapy, they are all tertiary form of prevention. Also, we have seen this form of medical intervention in animal surgery, radiation, chemotherapy, immunotherapy, and also you have to also modify your food to also get this done. So basically, we have all these ways to actually manage cancer globally. I hope that we will improve on that in Nigeria as it were. So we can do your chemical analysis. You can look at also the histology, the immunochemistry, also look at the cytology, do your MRI, PET scan, also look at your, those are forms in which we can use to diagnose and confirm cancer cases. Also, these are the recommendations that I have for us as clinicians today. Dogs should be as lean as possible without becoming underweight. So you must also look at the BMI of your dog, looking at the weight over the height. Dogs should be physically active every day. So take them on walk. That will reduce the risk of having cancer. Dogs should also avoid sugary food. Some of you put sugar in your dog food. You have to be careful because you can actually cause them to actually come down with cancer in their later life. So you can also put vegetables also in your dog food. That also help them, legumes and likes. Also avoid exposure of your dogs to chemicals, to paint, all those pesticides that we use on our dogs. So we have to be careful how we also apply all this because they can actually expose that dog to coming down with cancer in the long. So if your dog actually has cancer, don't use supplements to protect against cancer. That is not, it won't work because it will cause more problems for your dog. Also, mothers of the dog can also breastfeed from 6 weeks to around 10 weeks. Is actually very helpful because it will reduce the chance of the mother having cancer also, and also help the child to also build immunity to also not come. So those are what we can do in dog. And after you finish treatment, your dog survivors should follow the recommendation for cancer prevention. So that will also be very helpful as we look forward so these are what I want to know from my own perspective this morning. And thank you for listening.
All right, thank you so much, Dr. Ekundayo. Thank you so much. If you have questions, so we have 40 minutes to question and answer and a huge chunk of interaction, but we will just take all our lectures and trainings before we do the interaction. Now we are going to bring up Professor Ayefere to take over from where he stops and probably talk to us around the idea on diagnosis and okay, he's been spotlighted. So can you please, Prof, will you want to share your screen? You're muted. So can we spotlight Prof? Just a moment. I'm asking you to unmute. Prof, you can unmute yourself.
Okay. So I was trying to say that Dr. Antia will be taking the diagnosis. He's an expert in diagnosis, while I am an expert in the management. So I think he should go in that trend.
Okay, all right. So you're going to be taking the management. So, but will you want to share your screen or we should share from our own end?
No, I can share my screen.
Please go ahead.
Yeah. So you want me to go ahead to management right now before the diagnosis?
Yes. Exactly.
Okay,
No. Your slide. Yes. You can share your screen and share your slides.
Okay. Can you see my screen now?
Yes, we can see your screen. On presentation mode, if you don't mind, sir.
Yeah.
Beautiful.
Is it okay now?
Yes. You can go ahead, Prof.
Okay. So thank you very much. I appreciate the privilege to join the panel to discuss this interesting topic of cancer. I want to also appreciate my dean and the director for the privilege given me to be one of the anchor persons. I'll be talking on the therapeutic options and outcome in cancer management. Dr. Ekundayo have done justice to some of the introductory aspects, and because of time, I'm not going to go into that anymore. So I'm going to screen to the vital aspect I just want us to pay attention to. As he has said, we have the cancers, which are actually malignant tumors. And they include the carcinomas, the sarcomas, the leukemias, and the lymphomas. I'm not going to go into those introduction anymore because I want to pay much attention to management. So let's focus on steps in cancer management. Before you progress to look at management, there is need for signalment. Breeds of dogs have their different resilience to cancer. So most dogs, different breeds handle cancer cells in different ways. So you will not likely see cancers in some of the breeds, except at different age, especially when they are going toward the old age, 10 to 15, thereabout. So there's need for you to always look at the breed, then take care of the exercise, find out how this patient exercises, find out the food they eat, and all that. So history taking is vital to cancer diagnosis and management. Then you make progress to carry out exhaustive physical examination. The physical examination in cancer management is so important because it is through physical examination you'll be able to identify and also see the extent to which the system has been invaded or compromised by the cancer cells. So logically, physical examination go craniocaudally. You look at the mouth, you look at the eyes, you look at the ears, apart from taking the vitals. You look at the abdomen, the thoracic cage, and then the perineum. It's also important that you take blood samples so that you can evaluate the vital organs. In taking the blood sample, you can know the enzymes that are shared and be able to talk of the status of the various organs, the kidney, the pancreas, the liver, and all the vital organs. Cytology is also very important. During the case presentation, I will talk to you more about cytology and its relevance. Actually, cytology is one of just the basic things you do in diagnosis of cancer. So you take a fine needle aspirate, it enables you to do a kind of staining that can give a picture of what you are managing. Then hematology and blood chemistry are quite important to have emphasized on that. And then urinalysis. All this must be done in an attempt to diagnose. Besides, there is need for, after you've arrived at least try to know whether you are dealing with cancer, there is need for you to do a kind of incisional or excisional biopsy. The incisional or excisional biopsy of both are vital because sometimes cytology alone cannot give you a definitive picture of the type of cancer you are managing. So it's important you do excisional biopsy so that you can do a histological evaluation. Imaging is also very important. You take the different shots of the parts of the body that is suspected to have the growth. And if there is suspicion of malignancy, then you can go ahead to take a chest X-ray apart from the primary location of the cancer. In more enlightened community where you have more of good imaging equipment, CT scan is important, MRI is important, and ultrasound is also important. Then there is this vital aspect that is necessary in cancer management, and that is tumor staging. The reason we carry out tumor staging is to provide a framework or rational treatment plan. That is so important. Apart from that, it facilitates communication with the clinicians, with other clinicians. So tumor staging is so important before progression to cancer management. It also allows for uniform comparison and evaluation of treatment results. If you have cancers have been treated in different parts of the world, so when you carry out staging, it helps you to compare your data with data of other people that have carried out, and that is key to management. It also aids in establishing the prognosis. For instance, there is a World Health Organization method of staging. We call it the TNM staging, where T is the tumor size, and it varies from 1 to 4. N is the spread to lymph nodes, the adjacent lymph nodes, and then where M is metastasis. Now, where T could be less than 2 cm, T1 could be less than 2 cm, T2 sometimes 2 cm, T3 3 cm, and T4 greater than 4 cm. Now, with respect to spread to lymph nodes, now when cancer begins to spread, the first location you find a sign of the cancer is the adjacent lymph node. So N could be 0 if there's no spread. N could be 1 if there's spread to one of the lymph nodes, either the left or the right, that drain that part of the body. Or N could be 2 when there's spread to both lymph nodes. Now, there could be metastasis. And when there's metastasis, the most prominent point of metastasis are the lungs and the heart, most times the lungs. So M could be 0 or M could be 1. And of course, you can, if there is spread to the lymph nodes, and that you can do by biopsying the adjacent lymph node. With respect to the metastasis, you have to do imaging, do various imaging modalities for you to be able to diagnose, especially chest X-ray, which is available to us. So having staged the tumor, that cannot help you or help the clinician to communicate with the client on possibility of treatment and recovery. Now, this is quite important because cancer treatment has various, cancer itself poses much of psychological pressure on the owner. Of course, the owner will initially be worried whether the cancer could spread to humans. Apart from that, there is a social relationship between the pet and the owner. So the owner feeling that the pet has a cancer and that is going to lose that pet, it really poses psychological burden on the owner. And this is where the clinician expertise in managing the primary patient and the client comes in. The clinician should be able to communicate with the owner in a very precise way to give accurate prognosis of the case, and then be able to manage the owner psychologically. Just yesterday, I had a patient that was presented, and the patient has some tumors, and then the patient was 7 years old, and the owner did not have any other pet. And I have to counsel the owner to pick a younger pet so that the affection of the owner could gradually shift to the younger pet, because I know that at a point we may lose the primary patient that has the tumor. So that is very important, the skill of the clinician in doing that. So it, in terms of management and goal of management, it is important for every one of us to note that the main goal of cancer management is curation, but most times you don't have curation or complete curation. So what we encourage is to give the patient the highest quality of life for the longest period of time, for the owner to adjust, benefit from the social relationship, and then shift the emphasis of relationship to another pet. So that is the goal of treatment. So it gives room for the client to psychologically and physically adjust. And then our goal also is to employ the best treatment modality to maximize good outcome while minimizing toxicity. There are various ways of managing cancer in terms of therapeutics. For instance, surgery have been mentioned, chemotherapy has been mentioned, radiotherapy, immunotherapy, photodynamic therapy. These are various types of treatments that could be given. Interestingly, one single treatment may not suffice in most cases. So there could be a combination of surgery and chemotherapy, or surgery and immunotherapy, depending on the nature, the characteristic of the cancer. And most times we also do more of nutritional management. Nutritional management is key to cancer management, because during cancer produces some cells, of course, you have had of cancer, what you call cancer caucasic factors, which most times lead to cancer caucasia. So most times these factors causes some degree of leanness and depletion of the cells. And most times what you need to do is to give a kind of nutritional management that could take care of some of these depletions associated with cancer. Then apart from that, there is need for pain management depending on the type of cancer we are managing. There are some tumors that do not elicit pain or that. However, they destroy the system. There are others that are associated with severe pain. So management of the patient with good analgesic, both method and drugs, are quite important. But in managing this patient, we must be concerned about the vital organs because of the effect of the drugs in terms of toxicity. And ultimately, this is quite important to note. Euthanasia is an option in cancer management. As I talk about euthanasia here, apologize, there was a little interruption. Euthanasia is an option in cancer management. As I talk about euthanasia here, most times clients don't jump into euthanasia. I've managed patients where the clients sometimes just feel, I don't have enough money, can you put the dog down? Well, sometimes if I look at the condition of the patient, I may think of doing that. Sometimes I advise them that if the patient could be treated, yes, we go ahead to advise them. But ultimately with management, euthanasia, the point of euthanasia will come along the line of management. And that is, for us veterinarians, that is an option we have in terms of management. Let me present some interesting cases we've handled. Because of time, I won't spend much time. I just have some few cases. This patient, the name there is not the real name. I have to protect my patient. So I am using the name Casey. Casey is a 2-year-old, 38 kg Boabe Bish with that was presented with grade 5 lameness and swelling on the left carpal joint. If you look at the arrow there, you will see the swelling. This was the initial picture. Within few weeks, the condition of Casey changed so rapidly. The temperature was 39.1 degrees centigrade when she was presented. Respiratory rate was within normal range. Heart rate was 162, which was quite high, which also the respiratory rate was 25 breaths per minute, and the pulse was 160. Obviously, Casey, when she was presented, also had this swelling around the carpal joint and also had swelling above the carpal joint. Within a short time, Casey's condition just changed rapidly and the whole limb was swollen. And we progressed to look at examining Casey. All the lymph nodes at the point of initial presentation was not, the lymph nodes were normal in size. And we progressed to do a fine needle aspiration biopsy. By the time the fine needle aspiration biopsy was taken, tumor cells were found. You will see the picture there. You have evidence of different shape of tumor cells, which is a reflection of pleomorphism and sizes. And then we saw this round osteoblastic cells with relatively abundant basophilic cytoplasm. And then with few vacuolations and all that, which reflected that we were dealing with and osteosarcoma. We took the blood sample and all that to evaluate the vital organs too, which were just normal. And then we progressed to take some imaging shots. You look at the X-ray, the craniocaudal and the lateral view of the limb. I mean the cranial limb. You will see this hyperostosis with a kind of some bospherosity reaction and slight osteolysis of the ulna. If you can see, you will see a slight osteolysis of the ulna. Please give it out that we are dealing with osteosarcoma. And knowing that osteosarcoma is a very aggressive tumor and there's a likelihood of spread, we progress immediately to do amputation. So we did a complete amputation from the scapula down to that limb. You can see the patient there, a complete amputation. I want you to understand that the patient do so well with 3 limbs. This patient is able to right now ambulate fine, run and play around, and so he's enjoying his life. And we hope in few weeks' time we are going to do further screening to be sure that this patient is completely clear of the cancer. Let's look at the second case. This was a case of Kabi. Kabi is also a fictitious name. Kabi, a 6-year-old 55 kg Boabe Beach that was presented with a sub 3 centimeter, actually it was more than 3 centimeters, but let me just put it that way, pedunculated mass at the left cranial ventral region of the abdomen. You can see the mass. And we progressed to do cytology also apart from all our initial evaluation. And the diagnosis was mammary gland adenocarcinoma. Mammary gland adenocarcinoma is also one of those tumors that spread, though not too fast, but spread. And I've had several patients that I've managed and have been knocked down even after the initial surgical intervention, still died much later as a result of the spread of the cancer. So the hematology picture is as presented. The PCV was 28%. The total protein was 8.3 gram per DL, and other vital signs were just within the range. And then serum chemistry showed elevated total protein, high BUN and creatinine, which of course make us to be concerned about the state of the kidneys. However, we went ahead to further do therapy. So the therapy we recommended was surgical excision. Of course, the surgery was done and the patient recovered uneventfully. The third case is a case which we are still managing right now. This was a case of Darby. Darby is a 3-year-old 39 kg Boabe Beach presented with an ulcerative hemorrhagic cancer rather. The cancer was at least covered about 10 cm of the vulva area. And you can see the picture right there. And the owner noticed this about 3.5 months before presentation. Now, we looked at the cancer following diagnosis. Cytology reflected that we're dealing with metastatic transmissible venereal tumor. Metastatic because the inguinal lymph node was also infected by the cancer cells. And following cytology, the cytology of the primary mass was similar to the cytology of the inguinal lymph node, and the inguinal lymph node was markedly swollen. So looking at it, myself and Professor Mombowale often conference on some of these cases, we felt that chemotherapy would be the right option because transmissible venereal tumor is one of those tumors that is chemosensitive. So we placed this patient on vincristine sulfate at 1 milligram per 40 kg. And I saw this patient interestingly yesterday. The patient is recovering fine, but let me give you some light with respect to chemotherapy. in managing patients with chemotherapy, there are vital things that clinicians need to pay attention to. One, taking the blood sample and running full hematology to know the leukocyte level is quite vital, so that because chemotherapy causes bone marrow hypoplasia, and with bone marrow hypoplasia, the patient will be prone to secondary infection. So there is need for constant monitoring as the shot is given at 1 week interval. Before the shot is administered, there must be a kind of monitoring both of the vital organs and the hematologic status of the patient. And that should influence the spacing of the chemotherapeutic shot. That is important. So this patient is doing fine, and everything is going on well with this patient, and we are monitoring. Thank you for listening. Again, I want to appreciate the dean and the director and some of my collaborators in management of cancer. Thank you very much.
Thank you so very much, Prof. Quite enlightening, and I think the picture and the case you also managed made it a lot more very relatable. Thank you so much. I know we have questions. We have 40 minutes to go over questions. Just keep them, don't type them now. As soon as our third hub experts is done, then we will go fully into the interaction. I also see a couple of people I need to acknowledge. Just allow me, let's go through the third hub experts, present the diagnosis of cancer, and we can go into full interaction. Thank you once again, Prof. Back in, can we bring up Dr. Antia? All right, sir, I think you can unmute yourself, sir. You are co-host, and let's spotlight him. Fantastic, fantastic. You can unmute. You're still muted, sir. You're still muted. The unmute button is slightly down in your. Then I also want to ask if you want me to share your screen or you want to do it yourself. If you are having a few trouble, then I could initiate the unmute button for you. You will see something on the screen. All right, fantastic. You're muted now. Brilliant.
Okay.
Fantastic. Should I share my
So I
screen?
can share my slide now.
Yes, you can share your slide. Exactly.
Okay. Okay. Let me just thank the organizers and just
Your
all
screen,
protocols observed.
your slide is not yet up. Do you want me to share it for you or you want to do it yourself?
Well, I put it up.
Okay, no, so it's not yet up. So maybe I should do that from my end.
Okay, if that will, but it's on the screen now.
No, so you're not sharing your screen yet.
Okay.
So,
All right, let's see. Okay.
so I could just help. I'm already bringing up your slide.
Okay,
Brilliant.
let's just.
So you can go ahead, sir.
Okay, so. Okay, well, it's. I'm going to talk general about tumor diagnosis. From the discussion so far, I gather that this session is more of enlightenment than going to all the technical details. But So you have all the slides.
Okay, I
Many
think
of
your
them.
screen is up now. So
Okay,
if you
is
can
it
put
up
it
now?
on presentation, yes, up now. You can put it on presentation mode.
Okay.
Fantastic. Thank
Okay. So I'm saying that I have a lot of slides which I may not necessarily go through in detail. So I'll speak more on awareness of the need for diagnosis of cancer. If you are a practitioner, you are a pathologist, you are a surgeon, and you're interested in some of the technical details, the slides, I guess you have access to them. So, well, this is the outline, but the cases of tumors, a tumor is a disturbance of growth, but it's different from other disturbances of growth. So, and these are the things that make it different from other growth disturbances and what makes them dangerous. Now, why do we need to diagnose tumors? I know this sounds like a very basic question. I'm aware that in a lot of practices, a tumor is excised and thrown into the waste bin or into the bush with no effort made to diagnose, in the belief that, well, a tumor is a tumor. Once you cut it off and you flood it with chemotherapy, it doesn't matter. You don't need to know that is very, very unprofessional, if I may use the word. You need to diagnose the tumor because tumors are not the same. The difference between two tumors may be as wide as the difference between two canine diseases, like canine parvo or canine distemper or babesiosis. Those two diseases are quite different. So some tumors are the same. They are very, very different. And even within the same tumor, you can have differences that are as wide as between any two diseases. So you definitely need to, if you don't make a diagnosis, it's like building a house without the foundation. But there are other aspects of the diagnosis which will even help in the management, as we shall see. So another reason is the behavior. By behavior, I mean, like I said, each tumor is unique. How it will metastasize, how fast it will metastasize, whether it will metastasize at all, and how soon it will kill the patient or not kill the patient. These are all peculiarities of individual tumors. And if you don't know the tumor you are dealing with, you are not really doing justice. Then, of course, as has been pointed out, you have to treat. If you don't know the type of tumor, you are just going to be treating in a generic fashion. Let me put it that way. We've had about staging and grading. Those are aspects. Then very important, the prognosis. We do know that even after all the surgery and all the chemotherapy, many people and many dogs die a few years after. That is because the assumption is that tumors are the same. Therefore, if you manage them the same way, you will probably get the same result. It is very, 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 very far from the truth. Even even when you know the diagnosis, many people have died 2, 3 years after diagnosis, surgery, chemotherapy, radiotherapy. Why? Because the peculiarities of the individual tumor were not taken into consideration. And also, there was no monitoring. One of the key aspects of tumors nowadays is monitoring and prognosis. if you remove the tumor, fine, you've done your work. Are there no ways you should monitor how effective your treatment has been? Has the tumor and its first be completely removed? Or are there some cells still lurking around that will kill the animal or the person in a matter of 2-3 years or less? But the most important thing is that you must establish the diagnosis. Never remove a mass from an animal and throw it away. It is quite unprofessional. Then we're talking about a cancer register. Many countries, institutions, establishments, because of the increased prevalence of cancers, they tend to establish a register. I think maybe our faculty is thinking about something like that. But you cannot have a register if you don't know the identity of the tumor. Because as the first speaker said, tumor is not one disease. There are many diseases that comprise tumor. So you have to know which one you are dealing with. So the methods, many of the speakers have spoken about them. But like I said, diagnosing tumors now is like a necessary first step. The process of diagnosis with all the molecular markers and all kinds of sophisticated stuff. Yes. The process of diagnosis is pretty much established with all the molecular stuff, DNA and all that. But what is left now is monitoring the response to treatment and eventually the prognosis. So some of the markers that were used to diagnose, they're now trying to see whether either the same markers or the new markers can be used to follow up the tumor so that you can tell whether the patient is likely to survive in the long or short term. So it's not just enough to diagnose the tumor. Then, well, I'll just be very brief with this. A tumor is any swelling, but a neoplasm is a swelling that is a tumor. That is, I want to say cancer. Any tumor that identifies as a neoplasm, but neoplasm is rather technical. So nowadays, when people you have cancer, but it's only used in connection with the malignal tumor. The differentiation is another term that we should be familiar with. It means to what extent does the cancer resemble the tissue of origin? And it's not just an academic thing you need to know about it. We talked about, you've heard about staging, grading, and all that. It is degree of decision influences that. But the less differentiated it is, the more malignant it's likely to be, and therefore the more potentially fatal. But when we look at the comparison of benign and malignant tumors, as a matter of fact, the differentiating between benign and malignant tumor, some people argue that it's even more important than the identity of the tumor. Because most of the deaths are due to malignant tumors, because they can metastasize and spread to other organs. In most countries, it's that cancer is number one, and maybe cardiovascular diseases will be number two, or vice versa. But those two are always top. So then you wonder, with all the research going on, why Is it still like that? I don't know of any disease that is receiving as much research attention as tumors. Then one thing that we have to be familiar with if you're in this business of cancer is what we call paraneoplastic syndrome. These are the effects of tumors, or let's say the indirect effect of tumors, which are probably not predictable. Usually the effect is distant from the point of the tumor. Some of them are hormones or hormone-like, mediated by hormones or hormone-like substances. But the point is that para means beside. So they are not the direct effects. But for example, maybe we'll see later, there's a tumor in dogs that we call anal sac tumor. A paraneoplastic syndrome there will be hypercalcemia. So if you are going to do your workup and you keep seeing hypercalcemia, and you cannot, as you say, with bone disease or any other causes of kidney disease, any other causes of hypercalcemia, then you may suspect, even if you don't see the physical tumor, you may suspect. So these syndromes are very useful in diagnosis, in prognosis. For example, if you have an sac tumor, you remove the surgically remove, do you expect the hypercalcemia to subside? If it doesn't, then you may suspect that your job is not yet completely done. Well, we've heard about staging and grading. Well, this table of nomenclature, every vet that is in practice should be familiar with nomenclature. We're not going to go into them, obviously. But if you see a tumor, I think it's a tumor of bone, which people have talked about, you have to, if you think it is malignant, there's a name for it, osteosarcoma. If you think it's benign, osteoma, and so on and so forth. But you should be able to, even if you don't know any other thing about the tumor, if you can identify where you think it is coming from, you must be able to name it as a vet. So you can look at that table later on if you are interested. Then, like I've mentioned, when we were in school, we all thought these differences between benign and malignant. It was just like a table we had to memorize. But I can assure you, diagnosing a tumor as benign or malignant is like the difference between life and death, literally. Because we know a benign tumor, well, benign means good-natured and all that. It's not likely to spread. Malignant tumors kill because they spread. Benign tumors are localized, they don't spread. So if you can surgically remove them, then you've taken care of the problem. It's not always easy, no matter what method you are using, to distinguish them, depending on the degree of differentiation. So please take note. In the past, we had a lot of stories about, let's say, women that had lump in the breast. Maybe the surgeon felt it was malignant and did mastectomy, which, as you know, is a drastic procedure, only for subsequent investigation to find that it was actually benign. So there was no need for mastectomy. Surgical removal of the lump could have been curative because it was benign. And then vice versa. Something that you thought was benign may turn out to be malignant, and you think you have done your job because you have moved it. A few years later, you find all the organs are seeded with tumor cells. So it is very important. That's why you have the short list, as I call it, and then the long list, all the other comparisons, which we'll not be able to go into.
My apologies,
But
sir. Sorry, I want to quickly interrupt. If you can quickly just hasten up a little bit so that at least we can have a full time for the interaction, that would be nice. Thank you so much.
I don't how many minutes have I spent so far?
You
Okay.
spent more than 10, sir. Yes, sir.
Really? Okay. These are comparisons. Then, as pathologists, these are the things we look at to determine whether the tumor is benign or malignant. Signal end, we've heard about this. You need to know the age because most tumors are in older animals. The sex, you don't want to go and diagnose uterine carcinoma in a male animal. The breed, we've heard that some breeds are more predisposed. Reproductive status. Some tumors are more common in animals that have been spayed or hysterectomized or whatever than intact or vice versa. The history is an important point. You can even make a diagnosis of a malignant tumor, not the specific tumor, just from the history. If you now say 6 months ago or a year ago, this swelling was so small, maybe a peanut size, but now it's bigger than an orange and so on. You can almost guess that it's a malignant tumor because they grow fast. Weight loss, if animals are bleeding from any orifice, vaginal orifice, penile or urethral orifices, and you cannot find out the immediate cause, then you should suspect. We had a male dog that was having hematuria for weeks, if not months. And then with further investigation, we found that it was actually TVT. It was a tumor, but the TVT was hidden within the prepuce. So these are some of the things that is anemia, diarrhea, so many. Because tumors can affect any cell or organ of the body. So the history you will get may depend on the physical examination, all the parameters are there. Not all, some of them are there. But I want to emphasize that location of the tumor may seem unimportant, but there are some tumors, the same tumor, depending on the location, will be more deadly. Let me use that word, than the same tumor located somewhere else. We'll see that in a minute. These are examples of what they call cancer anorexia cachexia syndrome. When you see a dog like this, of course, you have to rule out malnutrition and but some other disease. And then when you see cancer, then this is what you call, well, we've heard a lot about imaging. Where imaging cross reacts with pathology is one, sometimes you've heard a lot about the importance of biopsy, oral fannula, or whatever. Ultrasound is now used to locate, these are for internal organs, to locate the tumor. Before it was common to do exploratory laparatomy, but I don't think that is common nowadays. And then you find that metastasis, you can detect metastasis by imaging, but imaging will not reveal all metastasis. That's why I said that there are some markers that are being developed to determine. There's what we call micrometastasis. You might have removed the bulk of the tumor, but the cells have been seeded into and as so few, you may have 1 or 2 in 1 million cells. So we call them macrometastasis. So then for these ones, you need to use other methods. Clinical pathology is routine. You may detect a disease because the fact that an animal has a tumor doesn't mean that every other thing is clear. For example, if your screening shows that the animal has liver disease, then you have to be careful how you operate on that animal. Because an animal with liver disease is an excessive risk. It's a risk for bleeding and so on and so forth. So these are some of the reasons why you must do not do surgery if you can without doing a thorough clinical pathology workup. Then these paranoid syndromes you can talk about, you can see many of them on routine clinical pathology, hypercalcemia, canine inner sac tumors, lymphomas, and some other tumors, increase in gamma globulin, immunoglobulin. When you see that, you suspect multiple myeloma. If you see hypoglycemia, there are many reasons, liver tumor and so on, one of which is tumor of the malignant tumor, which we call leiomyosarcoma. Then erythrocytosis. This is not very common, it's not as common as anemia. But if your routine workup is always showing that this man has a higher than normal PCV, very high, and you cannot explain, the man is not dehydrated, and then maybe you do your imaging or some other things, and you implicate the kidney, right then you can suspect a tumor of the kidney. Again, if your alkaline phosphatase is always very high, many people know alkaline phosphatase for bile duct obstruction and all that. But if it's higher, you can eliminate that probability. Then you think of osteosarcoma. Anyway, the point is that clinical pathology is not, it should not be negotiable if you are going to manage cancers, because you can pick up a lot of things. Just to show that even clinically can pick up some, that tumors that manifest in the blood, we call them hemopoietic tumors, like lymphoma. This is just an example. Gross pathology, these are the things you look out for. Each of them has implications for diagnosis and prognosis. For example, if you look at, let's say, melanoma located on the skin, the probability of recurring or metastasis is just about 10%. But oral melanoma is one of the most highly aggressive tumors of dogs. The probability is 60%. You can see the same tumor, different location, but you can see how the behavior differs. The same thing with the osteosarcoma. Depending on in fact, these locations are regarded as negative prognosis. Okay, these are some of the paraneoplastic symptoms we've talked about. Some of them you may not even associate with anemia. Anemia is so common here that you may not realize that some anemias can be the paraneoplastic syndrome, hypoglycemia, and so on. Well, so this is anal sac tumor. Well, this is just the cytology, don't worry about this. But 90% of dogs with anal sac adenocarcinoma will have hypercalcemia. So if you are confused as to is this CVT, is this anal sac tumor, is this mast cell tumor, whatever, if the some calcium is so high and consistently high, you cannot think of any other thing, then you are sure like you probably dealing with then lymphomas, which are very common, are also a common tumor. These are the use of cytology. Well, the reason I would say with this is because if I want to get going on cytology, people use a big stick to drive me away from here. The minimum you should be able to do with cytology is to classify it into whether it is a round cell tumor, a petechial tumor, or a mesenchymal tumor. There's a fourth one which many people will not be familiar with. That is the neuroendocrine tumors, which are called naked nuclear tumors. The criteria that I used to represent them are here. But you should be able to do cytology even in the most ill-equipped practice. As long as you have a microscope, a needle, and a syringe, glass slides, and stain, you should be able to prepare your cytology and make a diagnosis as to whether it is a epithelial, round cell, or mesenchymal at the minimum. Well, these are all examples. Well, we've heard something about osteosarcoma. This osteosarcoma, you can see the pink staining material here. That is osteoid. This will give it away as just simple cytology, which doesn't take you more than 15 minutes from sampling to diagnosis. Well, this is histiocytoma. Again, if you see this is mast cell tumor, You don't need any other technique. You just make that and you see this. These are much you can see from the granules. So the round cell tumors can generally be diagnosed without too much stress. This lymphoma, this plasma cell tumor, this is very common. We see so many cases of, because I think lymphoma, plasma cell tumor, osteosarcoma, of course, TVT, the amount of tumors we see most commonly. Maybe when my colleague, Dr. Olaifa, is giving whatever his role will be, these are TVT. We've heard about with vacuoles and all that. The one tumor you can diagnose, even with your naked eye, is melanoma. That is if it is so well differentiated that you can see the black pigment. Even as you are doing your fine needle, you'll be seeing that what is entering your syringe is black. You don't need anything more than that to say this is most likely a melanoma. I'm not sure you should stop there. You can still make your smear, but when you make your smear, you see all this black pigment. The only complication is that if you don't see the black pigment, you cannot rule out a melanoma because some of them are what we call amelanotic. They don't produce pigment. In any case, the principle of diagnosis of any disease, including tumors, is a positive result is a positive result. A negative result does not rule out the disease. Just to show that even though I said you could diagnose these round cell tumors, they are not always easy. So sometimes you have to use markers like this. There was a time we had one of the seminars, we had a lot of arguments as to whether it was TVT or something else. As common as TVT, you would think you're able to diagnose with your eyes closed, but sometimes they come in forms that you didn't expect. Histopathology, we've heard so much about it. We've heard about staging and grading. Grading is done by the pathologist because that's by looking at the smear or histopathological slide. Can you say, yeah, this tumor looks very undifferentiated or moderate differentiated. Therefore, the prognosis will be good or poor. Well, osteosarcoma, I just decided to use osteosarcoma as if I knew that many people will talk about it. Now, the image on the right is well differentiated. You don't even need a pathologist. If you look at the image on the right, you see the osteoblast and the collagen and the matrix and everything. So this just looks like bone. When you see this, especially if it is, but if you see this in the lungs, for example, you made your diagnosis there. Because almost they said at the time of diagnosis, about 90% of osteosarcomas will have metastasized to the lungs. So if you see this in the lungs, you've got your diagnosis there just from simple histopathology and even cytology, as you saw in the previous one. Osteosarcoma, but you're sure this one is not well differentiated. So I'm sure it took a long time if ever you can pin this down. Well, let's leave the grading and all that. Now, these are predictive factors. I just use osteosarcoma as a case study for purpose of this presentation. For example, because I feel that prognosis is even more important now. I would say it's more important than diagnosis, but now this is like step one. The step two is what you are doing. Will it make the animal to survive or not? Generally, osteosarcoma, large tumors, for high ALP, you can see your clinical comes in, and so on and so forth. Okay. I've said that metastasis is a key issue. If you can see the metastasis, like in slide A, you say yes, you can see it. But the problem is, what if you can't see the cells? By any, no matter how sophisticated the imaging technique present in existence, you will not be able to pick some of these cells because there are very few. There may be just one in a million. And the idea is that it is those cells that you cannot pick by whatever sophisticated means that will eventually result in the death of the animal or the dog. So that's why they are developing markers now that even after you have removed, is there we can either have tumor markers or whatever markers there are to be able to monitor and find out whether the tumor has been completely, you have completely removed it surgically, yes, but are there some cells lurking around somewhere that will eventually kill the pest of the animal? So in that case, there are some special stains you use. For example, this brown staining here is positive using some marker they call total TP3. It shows that you have micrometastasis. The B does not have it. Then finally, I just decided to, because my colleagues, we have this post-mortem rounds on Fridays. There are some of them who are very much into artificial intelligence, at least in terms of awareness of the idea. One of them has said that, soon pathologists will not even have to open up the animal. All you do is put it on a table and run some device, and all the lesions there we printed out on a computer. Well, it started like science fiction. So when I was preparing for this, I said, okay, let me see whether artificial intelligence can be incorporated or has been incorporated into more dialysis. The first one I came across, in fact, there was a picture of a young lady vet just using a device running through the skin of the animal with lumps or masses. And with 95% or so accuracy, it could tell whether the growths were benign or malignant. Like I said, they are very, very the distinction between benign and malignant is very important, because that's what we need to know whether the animal will survive or not. And they call it thermal imaging. I did not even know that malignant tumors produce higher temperature around them than benign tumors. But they were able to develop an artificial imaging linked with artificial intelligence that you can just run the device and it will tell you whether, so far, I don't know whether it's the same device will tell you the exact tumor, but at least you will know that you are dealing with a benign or malignant process without all the diagnostic methods we've been talking about. Okay. The machine was also programmed such that it could diagnose 7 skin tumors on the slide alone. But what I realized is that no matter the sophistication of the diagnostic technique, the AI, it starts with the basic diagnosis. It is the tumors you have been diagnosing over time. It is those characteristics that are fed to the AI machine. In fact, machine learning and AI appear to be inseparable, at least from the literature I searched. And then even tumors of the brain, the machine learning was able to predict the type of glioma. Gliomas are tumors of the glial cells, the astrocytes, oligodendrocytes, and so on. So I want to say that the future of diagnosis of tumors, just like in many diseases, is AI, artificial intelligence. Soon all this biopsy, cytology, histopathology, and so on and so forth, I don't know whether how soon, but the rate at which research on artificial intelligence is going, they might not necessarily be, those old methods may not be, but they still have to diagnose, because it is I used to think that AI meant something from outer space, but it is the diagnosis you have and the characteristic features of those diagnoses that you feed into the machine, and then you have your artificial intelligence. Well, thank you very much. I'm sorry if I've I know I've probably exceeded my, not probably, I've exceeded my time, but so thank you very much.
Thank you so much, sir, for an insightful session. Your last comments around AI just scared everyone. So we're just wondering whether very soon we will all have jobs when AI is diagnosing everything. Thank you. All right, so let's go into the participatory session. We have very limited time. We'll just stay with 15 minutes because our time. Prof, if you can stop sharing your screen.
Okay.
All right, so backend, we will go into the participatory session very soon. And I want to just quickly acknowledge Dr. Charles is in the room. Thank you so much for joining. I see you're also raising your hand. Dr. Bukar, a former director in NAFDAC. We have Professor James Olopade, also very instrumental in putting us together. Dr. Kunle, the president of SAVAN nationally, is here. Thank you so much. And I wish time will allow us to also hear you out. Dr. Anizon, thank you so much. Dr. Tunji Latinji Nasir, President Commonwealth, also a member of the Veterinary Council here. Thank you so much. We have Dr. Simiat Adeogun, the Publicity Secretary for MVMA. Thank you. I also saw Dr. Atag Bese. Thank you so much. We also have our own, very own Dr. Ganiena, a very senior private person, a member of the Veterinary Council, and a newly minted MNI. Thank you so much. I will still recognize a few people once I go through the session. But to kickstart into the brief conversation that we'll have, and we'll bring all our hub experts. Backend, please, can you just help me throw out a survey? I quickly created a survey just to give a sense of view of how frequent is just cancer survey. If you can quickly just help us quickly fill it, that would be the basis in which we're going to be discussing for the next 15 minutes. And I'm going to be inviting a few people at the back end to say a few things, practical experience. So there are just 3 questions. How many pets do you see in a month? Then how often is this cancer? Have you seen a case? Is it not so often? Is it very often? Is it always? How often? Then how is it for you as a private person to diagnose cancer? Very easy, fairly easy, very difficult. Once we get up to 50% participation, then I share the result. Because you see, when University of Ibadan got to us in Farmalab that they are going to be discussing cancer, I was like, okay, so how often? How real is the problem? Because you could be discussing something very rare and the people in the field cannot connect with it. So with this survey, we'll be able to know what the real issues are on the field and if we should actually be worried. I wish I'd added the last question from what Dr. Antia shared, that how significant will be the impact of AI in diagnosis in veterinary medicine. But that's too late for me to add now. So I'll just get a sense of it. So we have 37%. If we can quickly make it 50, then I will share, we'll end the poll. Then I will just, there are a few questions already on the chat box. I'm going to be reading out those questions. Once we have those questions answered, then we will now go, I will just call one or two persons to share their own field experience before we now bring up our hub experts to come up and say a final word. So we have 43% answering this. Let's count to 1 minute and then we're off. So we have 60, we have 55, we have 50, 45, 40, 35. I'm counting down actually. Counting down. So we have 30 seconds, 25 seconds, 20 seconds, 15 seconds, 10 seconds, 5 seconds. And then we end the poll, 55% participation. Let's end the poll. Yep, and then I'm going to share results. So can we all see the result? 40% treats an average of 1 to 10 dogs in 1 month. 38% treats an average of 11 to 50 dogs per month. 16% treats between 51 to 100 pets per month. And then we have 5% between 100 and 200 pets. That's quite a handful. And we have just 1% treats above 200 pets in 1 month. You must be making a lot of money. Yeah. So how frequent do you see cancers in dog? 7% said they haven't seen a case before. 7%. 74% said not so often. 13% said often. 6% said very often, and 0% said always. So we have a major part of this survey saying not so often. So that's why I asked the last question. How easy is it for you to diagnose? Because if you say you're not seeing, doesn't mean that your diagnosis is very poor. So, but of course, we have 8% said it's very easy. I believe they are mostly from the academia and senior vets. 61% said fairly easy. We have 16, which is rare. We have 30% said it's very difficult to diagnose cancer, 30%, and that's very substantial. So now let's bring down the poll. Let's ask a few questions. I have a few questions, I think 3 questions on the chat, and I will want to bring up those questions before I start calling people out. So the first question, just a moment. Just a moment. And backend, can you please bring up all our hub experts? Oderinu Tofik said, Debbie's case is similar to a case I handled last year between August and early October. The case did not resolve completely after 7-8 doses of vincristine. What might be responsible? The TVT stopped growing but didn't resolve completely. So who's going to take that question? Prof, I think you should go ahead and take that question. He said he treated the case. You were the one who talked about Debbie.
Yes. Well, I quite understand that question. Yes, there's a point where chemotherapy may not progress. You know, I did inform you that sometimes we combine chemotherapy with surgical excision. There is a point even in chemotherapeutic exercise that you may not be able to progress because of the effect of the chemotherapy on the patient. Because with chemotherapy, you are going to have bone marrow hypoplasia, and that predisposes the patient to very serious secondary infection. And then you also have some post-treatment syndrome, including diarrhea and some other things that follow. They tell you that you have to space the therapy at that point because you are interested in the life of the animal. Depending on the chronicity of the tumor and its unique characteristic, a single therapy may not be able to do that. So you may have to combine chemotherapy with other adjunct therapy. Thank you.
All right, thank you so much. Dr. Samuel, at what stage does the patient start feeling pain in cancer? This is being asked by Orolu Adedeji. At what stage does the patient start feeling pain in cancer progression? Is it at the initial stage or at as the cancer progresses? Yes, Dr. Samuel, you can unmute yourself. Backend, please, can you unmute Dr. Samuel?
Okay.
Fantastic.
Thank you so much. Like I mentioned earlier, there are varying reports as regards the onset of pain. Like we also said about the issue of wound, that when you have a wound that is not healing, So, and you also that wound can also be a risk factor if a wound is not healing. So pain actually, you cannot pinpoint and say that the pain will start at the onset or it will be at the middle or but we know that pain actually, because we just did research of recent about angiosarcoma that we call imagisarcoma, that we discover that most of the cancer patients, they observe pain as their first symptom that they observed. So sometimes it could be at the onset, sometimes it could be in the middle, and that's how we cannot say a cancer is linked to an onset form of pain. So that's what we know. But it could come along the line, but when you observe pain and that is not going, then I think you should go and investigate further.
Thank you, Dr. Samuel. To Dr. Antia, why using chemotherapy? This is being asked by Dr. Victor. Why using chemotherapy for management of TVT? Can one administer antibiotics to take care of secondary bacterial infection, which may take advantage of the likely damage of the damage to the dog immune system? So while you're doing this, can you do antibiotics? Although it's more of management, but again, maybe when you say
it's more management.
Yes. So should we give it to Prof?
But what I can say is what I've said before, that the issue is not so much whether you have done the surgery and the chemotherapy. The issue is that there are cells that you may not have got rid of. You have got rid of the mass. They say before you can see a tumor mass, it's about 10 billion, 10 raised to power 9. I don't know whether it's 1 billion or 10 billion cells before you can even see it. So you have millions of cells that may escape. And those are the ones that will eventually become fatal. So the fact that you have given you are doing chemotherapy does not mean you have cured the disease. In some cases you have, but I do know, at least from people that I know have had cancer, that even after all that has been done, in a few years, 2-3 years, they are dead. Because those procedures are just things to keep the animal alive for as long as possible. They are not completely curative because they are not being monitored. There are different markers now that you even be following the progression of, are there tumor cells still present doing their damage, or have you completely got rid of, by looking at some of the tumor markers and even some of the serum markers.
Thank you so much, sir. To Prof, you can add your thought, but I want you to also answer this question. How do we go about setting up National Cancer Registry? Somebody is asking, that's Dr. Tijani. Is anyone available now? And how do we go if we need to set up a cancer registry?
Well, I don't know if there's any national.
That's to Prof. If you don't mind, sir, that's
no,
Prof.
I think he's in the right position to answer.
Oh, to
that
answer.
question.
Okay, fantastic.
Let him answer, please.
All right, sir. All right, sir. Go ahead, sir.
Well, that was administrative. So anybody who has the answer is in the right position. But what I can say is that I'm not aware of any. It's something we discuss quite often. Even the University of Ibadan, well, the UCH has a cancer registry that I'm aware of. But in the faculty, I'm not aware that there is a cancer registry. And that is why the aspect of diagnosis is important. You are not going to put in the register that you diagnose a tumor. Because those who responded and saying tumor is easy to diagnose, tumor is difficult to diagnose, tumor is I'm wondering what they are talking about. Are they talking about tumor as in just a growth that you can recognize? Or a tumor you have diagnosed and say, yes, this is squamous cell carcinoma, or this is cutaneous histiocytoma. That is the type of thing that can go into the register, not that you saw a tumor. So, but I think there are some steps. The director of the VTA will probably be in a better position service to have a cancer register in the faculty, because we are beginning to see a lot more of these tumor cases. But it has to start from the institution.
All right, Prof, you want to add your thoughts to the
Yes,
two?
let me add my thought. I think that is a take-home message. We have to start working more articulately on establishing a cancer registry, which if we establish we can also synchronize with other institutions to make it a national thing. Then apart from that, with respect to management of cancer patients is critical, because here you are not doing a straitjacket thing. The first question that you asked me to answer with respect to a single therapy not being able to take care of that. There are other forms of therapy. You can use cryosurgery or cryogen to at least destroy the cancer cell. Ozone therapy is also coming up now. My big Oga senior colleague, Dr. Biade, is quite good at that right now. And with respect to cryosurgery, there are a few of my good friends that are good at that. And some of us, we have been trying to at least use various methods to take care of that, especially when a single therapy do not work. Now, with respect to antibiotic therapy, there is need for us to be a bit careful when it comes to use of antibiotics because of the residual effect alongside with the cytotoxic drugs we are using, because the liver and the kidneys bear the brunt of the effect, the toxic effect. And as I told you, you try to manage the patient with a mind to minimize toxicity. Otherwise, the patient will not survive. So you have to be clinically sound and let me put it, prudent in the use of therapeutic options in management of cancer. Thank you.
Absolutely, I agree. So I'm going to quickly do something because of our time. Let's call Dr. Bakken. You bring up Dr. Kunle Abiade upstage. You bring up Dr. Tunji Nasser upstage. You bring up Dr. Charles. He will take one minute and just share just 1 minute of their practical experience. Then we'll bring back our hub experts and take a few questions. So Dr. Kunle Abiade, I know everybody knows your place in Lagos as a go-to place for most of these very difficult, like really very difficult cases. So can you just add your thoughts to how often do you see cancer and what your experiences are? Can we just, exactly. Fantastic. Help bring up Dr. Tunji also in stage. You can go ahead, sir.
Hello, and this is quite a very interesting topic. I greet all the experts, and they have done a good job. I mean, cancer is becoming a very a big issue now. A lot of dogs are coming down, as Dr. The first expert said, Dr. Samuel, that some of our dogs are being fed with junk. So we have had a lot of cases, we have different cases, but just one interesting thing that which Professor Yarefe said is that cancer is a multidisciplinary. You have to use a multidisciplinary approach, especially in the diagnosis and management now. Just as what Dr. Antia said, now very advanced methods are being used. Cancer markers, the one you said the other time. In terms of management, yes, we have decided to use some other modalities. And one of the modalities we are using is ozone therapy. We have been able to manage some of cancer cells by doing an intratumoral. Okay, we are able to locate either by ultrasonography or directly, we are able to locate the cancer cells or tumor cells, and we infiltrate them with ozone gas. And once we do that, we're able to manage a mast cell tumor, which is a cancerous growth, and we are able to cause a total apoptosis of that growth in the digits of one of our dogs. We're supposed to do a separation or amputation of the digits, but we couldn't do it because the dog was not capable of receiving, going through that surgery because of some other factors. He had azotemia and all that. So now we are able to do that, and after 7 intratumoral infiltration into that, directly into the growth, we got a very good result. And we have done some other couple of therapies like that, and we are finding out that this is a very an alternative therapy to chemotherapy. Chemotherapy is good, but in cases, and we are still doing a lot of researches, so people with such stubborn cases that maybe you have used chemotherapy and it's not working, please, you can refer to us and we can use such therapies to effect it very. It's not as toxic as the chemotherapy protocols, but we're getting very good results, and we're hoping that with more research to be done, it will be one of the easy method, easy chemotherapy protocol that will be used for cancer. Apart from cancer, we are using it to replace even antibiotics now. Our antibiotic use in pet care is so low. Now we treat parvovirus enteritis without antibiotics now, and we get it off within 4 or 5 days. So these are the new protocols that some of us will have to get used to, and we have to learn and begin to adopt as part of our protocols. Thank you very much.
Thank you, Dr. Kunle. That's one of our fathers in practice. Of course, new knowledge are emerging on a day-to-day basis, and this very beautiful interaction between the knowledge reservoir in the university and the extensive practical experience we have on the field, merging together can solve a huge problem. Now, Professor Olopade said the Committee on Cancer Registry is on the way. So as soon as we have that, Prof, we'll be glad to know. Dr. Samuel also said he wants to pass a survey across on cancer. We'll be happy to have the link when you have that and share it among everybody who will participate. Now, let's go to Dr. Tunji Nasir. Briefly, please, you want to talk about what you think around cancer practically, and also share, I think Savan is hosting an event this evening. You also want to invite others. Briefly, sir.
Thank you, Dr. Femi Kayode, and all the experts for the very good job that they have done. I was captivated for the past 2 hours, and I think that's fine. Yeah, I want to say something about this cancer for about 30 seconds from my experience. I'm not going to talk about diagnostics and the management and all that, but the human toll. It was Professor Eyarife who actually mentioned it in his delivery about the fact of the psychological effect the diagnosis of cancer could have even on the client. And I've encountered a lot of clients that are practically broken down when we tell them the diagnosis that we have had on their dogs. And I think veterinarians should be mindful of the fact of how they break the news of cancer in dogs or in pets to a lot of clients. You don't want to have somebody to develop high blood pressure or even collapse and slump in your practice. It's real, it's very real that you know how to communicate that news to them. And because a lot of us see these issues when they are already almost late, because clients will always make the decision to come to the clinic very late. It's almost after everything is done with their pet that they are coming. And then diagnostics are very expensive. Management is very expensive. So most of the time you lose about 80–90% of these cases, but it's good news now that Dr. Belli said ozone therapy would help us, because I know the only options is surgery, chemotherapy, that will be available for most of us as practitioners We don't have radiotherapy. We don't have some of those, so all those modalities that are being used now for management. So we should also make sure that we encourage people to do health checks for their dogs, so that when these things are developing, we also know, you know, in the ways that they do come. Now, don't let me waste a lot of time, because we're talking about Saban now. I want to ask you whether you are a small animal practitioner. Of course you are. Do you want to change your situation in 2024? Of course you want to. Are you also prepared to practice better veterinary medicine and business than you did in 2023? Of course you want to do that. That is why I'll be inviting you to our first delivery for this year, which will be taking place just in another few hours, about less than 3 hours, at 4 p.m. when the meeting will teach you the following. One, how to reduce overhead costs, your draining pipe losses, and how to up your profits in your various practices. How do you effectively do a medical consultation that can also result in better profit for you in 2024? Then how do you brand your practice? And how do you offer better customer services? These are the things that we're going to look at 4 p.m. Courtesy of Saban, and I want to invite everyone on this call to join us at 4 p.m. Thank you so much, Dr. Femi Kayode.
Well, I'm receiving the advertisement with a big smile, because money is very important. After all is said and done, what goes into the account will be very significant. But we're getting a popular demand from people that the issue of not using antibiotics in parvo treatment, that looks like a cutting-edge technology that Dr. Okunle Abiade has thrown up. 2 people have said we should maybe have a session with that. But again, I don't know what Dr. Kunle thinks about that, but we'll be contacting you regarding that. So please, in another 10-15 minutes, we'll be done. What we will just take briefly from Dr. Charles, then we will bring up our hub experts to just in two or 1 minute summarize what the take-home lesson should be from today's meeting.
Yeah, my colleagues, I love you once again. Meeting you again is interesting at this time in the year. My own emphasis, what I want to lay the emphasis, where I want to lay the emphasis is on prevention and certain markers or certain things that had guided me while in the course or in the course of the profession. For 37 years, thereabout, I've been in this profession and working in the abattoirs and then doing the clinics, pet clinic before moving to poultry and back to corporate sector, being in abattoirs. You can see that I believe strongly that dieting has a lot to do with cancer or tumor. Ruminants, I had only seen one case of ruminants having cancer, and it was a provisor. What makes a provisor? In my farm, I had some sheep. During the dry season, they used to eat fecal dropping of birds, which has a lot of uric acid. And one sheep actually was drying up. One ram was drying up. We didn't know what was wrong. We thought it was intestinal obstruction. Maybe he had eaten leather, pure water, or whatever, packaging materials. But when we opened or when it died during the postmortem, we saw a lot of mass in it. And then I think dieting has a lot to do with cancer, with tumor. You know, the carnivores and the herbivores. The herbivores rarely have cancer. And then another thing I want to discuss in the preventive aspect of cancer, and early diagnosis is as good as treatment. In human, in the kind of practice we have in Nigeria, even in human practice, is when the animal or when the human being is sick, he goes to hospital, it might be late. Most cancers are detected at the stage 4, stage 3 to stage 4. But stage 1 would have, the diagnosis would have been treatment, so to say. And how can we escape from it? The spike in cancer now is so high. How can we escape? Is the system we have in Nigeria does not give you time to check, not routine check. routine check is paramount. Once you come into the age of 35, 40, and we start moving, if you're human, for men or for male, for different gender, there are kind of checks you're supposed to be doing yearly or by, depending on what your physician, you need to have a physician. Sorry, you have a physician. You need to have a family physician that will be, as they'll be, the way we call up our clients, the way they will call you up, come for this check, and not when it is late. Then finally, in human, I think I differ with the first speaker. We have a lot of infectious causes of cancer in human, more especially those that cause Kaposi tumor, human papillomatosis, like cervical cancer, that leads to cervical cancer, cervical malignancy, and then Epstein-Barr. Epstein-Barr that causes bucket lymphoma. Well, I've spoken like a trader, which I'm supposed to be. Thank you.
Thank you so much, sir, for being very brief. So let's take Dr. Samuel first. Dr. Samuel, I'm going to be sharing a link from Dr. Samuel on the cancer research. If you don't mind, please quick if you have 1 minute to summarize the take-home points for today, then we'll now go to Dr. Antia, then we'll now wrap it up with Prof. Then we'll take our post-quiz. Please don't go. In another 10 minutes, we will be done with this meeting.
Thank you so much,
Samuel,
Dr. Femi. Thank you so much. So, well, I want to thank you for the opportunity again. Thank the director of VTH and the dean of my faculty and my mentor. Thank you so much. So, we have heard today that cancer is real in animal, and I think we should take that. And I want to say that from what we have seen so far, that when you spay your dog, when you neuter them, it has a way of also increasing their life expectancy. So that can also be, if your dog is not being used for breeding, you can advise your client if it's not being used, because when they spay their dog, when they neuter, it also has a way of increasing life expectancy. And we've also seen that physical activity for your dog can also improve or reduce your risk of having cancer. And we have seen that you should be careful about all those chemicals we use in our environment, pesticide, so those actually can have a lot of effect on our animals. So we should take note of all these things. They are very, very important. And we also know that we should also take note, one thing I should mention, that let's add this to part of our history taking. When we take history in the clinic, if any dog actually, maybe the parent dog have come down with cancer before, that could also be a risk factor to that dog. So I think these are what we should take note of. When a dog is having swelling, don't just rule out anything. We should put cancer as a differential in anything that we're doing. So those are what I would recommend. And also, I think I'm happy that the director has mentioned that the cancer registry is on ground. We need to have the data to know much about cancer epidemiology in this country. I think that is also important. And also, maybe I will also advocate to the Veterinary Council of Nigeria or the relevant body. We need to have a specialized cancer treatment centers. If not everywhere, we should have them maybe in 6 geographical zones that we know, yes, we have this. And also, I will also say that, again, cancer is real. I recommend that we go through the slides. Cancer is real in animal, and don't rule out cancer. Thank you so much.
Fantastic.
And please, lastly, please, we want to create a data, and that's why we are coming up with a research at the moment to actually we want to start with the veterinarian. Let's know how much you know, then from there we'll move. So that there's a survey that we are doing, a national survey that is on the platform. Please, you can look through it, please, and help us feel. Thank you so much.
Fantastic. Thank you, Dr. Samuel. Dr. Antia, what should be the summary point we should go home with today? You're muted. So the same way. Okay, fantastic.
But it's okay now.
Yeah.
Yes. Every disease begins with a diagnosis. And the earlier the diagnosis, the better the prognosis. Why cancer generally has such poor prognosis is one, the diagnosis, the cancer is not detected early. Like I say, it takes about 10 billion cells for you to see the growth that you call cancer, during which a lot of havoc is going on. So we need early diagnosis. Tools are being developed for that. Secondly, we actually need to establish the diagnosis. So in the whole of Nigeria, I'm not aware of any place where markers, histochemistry, immunohistochemistry are routinely used. If you do not have those facts, it will be difficult for you to manage cancer. You can do what you need to do, but you will not be able to manage. So we need not just a national, we need a national diagnostic lab. It can serve both humans and vets. These markers you are talking about, they are very expensive. It will not be proper to expect every university or every practice to have this set of markers. The caseload may not justify the cost. But if you have a national, even very rich countries like Germany and so on, they have what they call National Histopathology Center or Cancer Center, where those tumors you cannot diagnose by cytology, histopathology, and the rest, you put it there, they will put all the markers. They have enough caseload to justify the expense. So what is that? We should have that if we want to move with the rest of the world. And then we should also appreciate that diagnosing cancer is not the ultimate. We should look for ways of monitoring the response. Cancer cells are over 1 billion, like I've said. Each of them is different. Believe me, some of them are resistant to chemotherapy. Some are resistant to radiotherapy. Some are resistant to almost anything. They are so heterogeneous. So we have to look for a way of monitoring just as we monitor diabetics, to see whether they are responding and what their status is. We need to be able to do that for cancer. Otherwise, we'll be doing all the correct things and the patient will be dying 2 or 3 years later. Thank you very much.
Brilliant, Dr. Antia. Thank you so much for this summary. So let's take Prof.
Thank you very much. First of all, I want to appreciate my dean and my director for the privilege, and also PharmAlert for the wonderful work you are doing. With respect to the presentation, I want to encourage all clinicians to approach diagnosis in time, and where you are handicapped, refer your cases to establishment where good work can be done. That is important. Apart from that, be conscious of your client and their emotional constitution. Be conscious that pets are part of the family. And anytime you are managing a particular pet, understand that the client is emotionally attached. And whatever happened to the pet affects the owner. The social cost cannot be quantified with the financial cost of that pet. Then apart from that, I want to encourage us to approach management with keen attention. When you have issues with management, conference. Here I conference with the pathologist and with my friends in medicine in establishing the right diagnosis for management of pets. I want us to do that. And conference with private practitioners. We are connected in Savannah, we are connected. So that is what I want to encourage us to do. Thank you very much for the opportunity.
Fantastic, fantastic. Thank you so much, Prof. We're going to do 3 things at the same time. I'm going to share my screen. We will take the post quiz, which is a very important part of this meeting. Then I will also get back end to also unmute Professor Lopade. At the same time, I think he's been also very instrumental in putting this together to say a few words. But we are going to be taking the post quiz and Professor Lopade also speaking at the same time, if you don't mind, so that we can manage our time and finish probably in another 5 minutes. So let's bring up the post quiz. It's important. We want to gauge the knowledge gain. At least if you failed it at the pre-quiz, you should be able to have a good score now that you are almost an expert or a guru in cancer management and diagnosis. So please, if you don't mind, kindly quickly help us fill the post quiz so that we can have a measurement on how much you have learned. We're also going to be sharing the analytics of today's meeting, the knowledge gain, the data we're able to gather, and a few things with the university so that they know the impact of the meeting today. We had over 400 registered at a point in time. We had almost 250 join. People come in, go out. So averagely, we have 300 vets participate in today's meeting, and that's a good thing. So, Professor Olopade, I want you to, while the post quiz are going on, just kindly hop up and say hi to us, if you don't mind, sir. Thank you.
Hello. Hello, can you hear me?
Go ahead, Prof.
Okay, I hope I'm yeah.
Okay, so we can, yes, we can hear you.
My dean has spoken. I think that and the other experts have spoken. Our job is to be at the background to make sure things are working well, and lessons learned from here. We are back to the hospital to make changes to make our services better. So I also really appreciate the senior people in the field who also gave their own insights. It's the real town-gown connection. I'm very sure we are all deep. Thank you very much.
Thank you so much, Prof. We appreciate this. So for our post quiz, we have 44% participant. Can we just briefly push it? Then we'll answer the questions together. Just push it to 50%. We have 46. So let me do a countdown of 1 minute. We have 60. We have 55. We have 50. We have 45. We have 40. I'm doing a countdown to 0. We have 35. We have 30, 51% participation, so it's good, but we can push it a little bit further. Then we have 20, we have 15, we have 10, we have 5, 4, 3, 2, 1, and 0. Thank you so much. So back end, please, can you help us stop the poll? We have 56% participant. I think we should bring which of our hub experts will give us the answer. So some still failed it. Hey, then we were sharing the video of the recordings of the meeting, but some still failed it. So which of our hub experts is coming up to share the answers with us? Who should we call? Should we call Dr. Samuel? Should we call
Dr. Samuel?
Okay, Dr. Samuel, fantastic. So please, back end, can you bring up Dr. Samuel and spotlight him? Cancer in animals is a death sentence, true or false? True or false, Dr. Samuel? What's the answer?
Okay. Yes, it is false.
Oh, false. So at least 75%, 90% got it as false, 10% still said true.
There are cases of
it's false. All right, thank
what
you.
you have said. Yeah.
Thank you. Then transmissible venereal tumor is the most common cancer in dogs. True or false?
That is also false.
Okay, that's false.
Yes. We have the images, sarcomas, the example, the lymphomas. Those are the most common in dogs.
Whoa. So 75% said true. Whoa, we need to repeat this class. Genetic predisposition is a risk factor in animal cancer. True or false?
That is true.
Okay, 94% said true. Fantastic. I think we all listened to that. Radiotherapy is one of the intervention options in the treatment of animal cancer. True or false?
That is true.
93% got it correctly. Education is a secondary prevention method. True or false?
That is false.
That's false. 38% got
It's
it
primary.
correctly.
It's primary form of prevention method.
Oh, okay. 62 got it wrongly. Now, I don't know what to say, but again, we'll issue some people a receipt. Thank you so much, Dr. And we can stop sharing the poll. Let me just run through a few announcements, then we will call it a day. All right, so we now serve as a private CE providers to the Veterinary Council. So this is one of those lectures in partnership with University of Ibadan. And if you're here from any other university, please, you can kindly approach your dean and come up with a topic. Your dean or your director of veterinary service already has a letter through the chairman of Kodak, dean and then directors. You can simply just approach them so that we can choose, you can choose a date with us and we can bring up your hub experts and then we can have these sessions through and through. So please, we now serve as a private providers for Veterinary Council. How do you now be part of it? So the sessions are free. Backend, please, can you help me bring down this poll, the dialog box for the poll so that I can read up. Just help me completely bring it down. Just a moment, I think I will need to do it myself. Good, I've done that. So what do you need to do? Our TECLA sessions now, it's free, but we take a token of 3,000 now, new year, new price, 3,750 to have your accredited certificate from the VCN and your CE point submitted to the Veterinary Council. All you need to do is to make payment to our provider's account and send a message to Dr. Nancy. We are missing Dr. Tunisia. She's a big woman now, got a government job with the Niger State government. And just to also advertise, we're currently looking for a replacement for her. If you know a vet, very good communication skill, ability to communicate, organize. We're very open, good spoken English, right? That's very important for meetings like this because of our international audience. You can just send me the person's CV and we'll take it up from there. But right now, Dr. Nancy is standing in for Dr. Tumsia. So you send a message to Dr. Nancy with this number, and then we can issue you your Veterinary Council accredited certificate. What other topics will you want us to address? You can please kindly drop it on the chat box so that we can address. Somebody is already saying that we need to take how to attend to parvo without antibiotics. If that's a topic of choice, please let us know. And if you're a member of the university, the topic of choice is up to the university. If there's anything the university is strong at and you want the general veterinary community to be aware of it, and you want to lead that topic, we are very open. We give you the platform, you provide us the hub experts, and we, in this partnership, make it a goal. Please, you kindly follow us on all our social media handles. We're on Facebook, we're on LinkedIn, we're on YouTube, we're also on Instagram. And then before I say thank you for coming, I don't know if the dean is still around, Professor Olufunke Oladevi, is she still around to just thank us? I want to thank you most sincerely, Dean, for hosting this TECLA for January. You still have one more slot. Every university has 2 slots within the year, and we're looking forward to what we can do. To all our hub experts, to Dr. Samuel, Dr. Antia, to Prof. We are extremely very, very grateful. And maybe we should bring up the dean one more time to please thank our audience and then give us like a closing remark. Then we thank everybody for coming.
Thank you very much, Dr. Femi. On behalf of the Faculty of Veterinary Medicine, University of Ibadan, and CODAT, Committee of Deans and Directors of Nigerian Universities, I want to say thank you to all of our audience, everyone that came. Thank you so much. And to our experts, Professor Yarefe, Dr. Antia, Dr. Samuel Ekundayo, we are always proud of you. Thank you so much. Director, thank you for your cooperation. And to all, Farmalart, thank you. God bless you. And bye-bye.
All right, so that brings us to the close of the event. Thank you so much for everyone. Everyone can unmute yourself. You can say hi. You can do whatever it is. The next 5 minutes will be left open. We want to thank you all. See you in February while we are hosting another university to host the entire veterinary community in another mind-boggling engagement with the veterinary community. Thank you, and do have a lovely afternoon. Please